Hello, everyone, and welcome to the sixth episode of our podcast. Today, we are going to talk about falls, and that's a very pertinent subject for us because the majority of hip fracture patients we see coming into the ward are as a result of a fall.
Hello, everybody. I'm Anthony Johansson, and yes, every day when I get to see somebody, I've the question of why did she fall, and what can I do to try and prevent it happening again, knowing that a quarter of the people I see presenting with a hip fracture will go on to have another fracture at some stage in the future. So what should we do about that? Well, Rehan, what did they teach you about falls in medical school all those weeks ago?
Many weeks it feels like. And in the UK at least, we are doing a lot of problem-based learning. So a lot of the cases we cover, patients who fall will have very scary issues like cardiology problems such as arrhythmias or epilepsies. Or I remember that there was one where the patient was just had a lot of drugs, so polypharmacy, which is a bit different. But at least from the ward, from my very long career working as a doctor so far, the patients I have seen who have fallen, there hasn't been any cardiological or any neurological issues. It seems they haven't actually had a reason for falling, and the most common reason or the most common patient I've seen who has had a fall will be when I come in the morning and the nurses told me the patient has had a fall and they don't actually remember falling.
Indeed. So cardiology and neurology have all the glamour, but actually they're almost irrelevant to the sort of people we're talking about. People like Grace, it's very unusual for her to have had a cardiological event. We know that because we took very detailed history from a couple of hundred people a few years ago to try and tease out exactly why they were presenting. And we did find some people with medical causes for their falls, but in the majority of them that was orthostatic hypotension, low blood pressure when they were up and about. It wasn't an arrhythmia or another sort of form of electrical disorder like epilepsy. It was something relatively less exciting, but that was 5 or 6% of the total number of people who we saw presenting with a hip fracture. 20% of them couldn't give us a history because they have cognitive problems that meant that they didn't really remember what had happened, and nobody had been there to tell us what had happened at the time of their fall. The vast majority of people came over because they came in because they'd had a trip or a slip, indoors or outdoors, or because they had poor gait and balance problems. So the challenges that they're throwing at us and the types of history that they're telling us aren't really the types of history that you get taught about at medical school. And there's clearly a need for us to think about the risk factors for people falling over in a different way from the way in which you're taught and everybody gets taught about falls. So risk factors for falls, it's commonly a topic. They like you to be able to give nice lists of risk factors for falls.
In terms of risk factors for falls, just thinking off the top of my head, a patient who's older, for example, a patient who might have some memory issues, a patient who has a walking stick, poor balance issues. I think that's just off the top of my head.
So yes, and it's very easy to do epidemiological studies. You take a group of patients who have had a fall and you compare them with a matched group of patients who haven't had a fall, and you subtract one from the other, and you can see that the fallers are more likely to be old, they're more likely to have a walking aid, etc. Just as you said, it's very easy to do those studies. So there's loads and loads of them out there, and they're nearly all broadly useless. They're just giving you long shopping lists of questions that you might think about asking. But you don't really want to be asking this question. How old somebody is may be a risk factor for their falling, but it's not a treatable risk factor. They're going to be the same age, whatever intervention we throw at them. So what you want to be doing is trying to find a way of identifying things that are important factors, that are amenable to treatment or to change or into intervention in some way. So we want a slightly different perspective on it. So you really want to look at the literature, not about risk factors for falls, but interventions that might be useful for falls. So where do you go lists of interventions that work.
Well, we've mentioned it on a couple of our podcasts now, but the place to look seems to be the Cochrane reviews. And I only realised this now, but the Cochrane reviews are the same Cochrane that's on a few buildings in Cardiff. And that's Archie Cochrane, who I learned is an epidemiologist who used to work in South Wales. Is that correct?
That's right, working with the epidemiology in the mining communities in South Wales. Yeah, so Cochrane will look at the literature in a very critical fashion. They'll get rid of a lot of poor quality information, and they'll give you a sense of where there's good evidence that something's worth looking at. So the Cochrane systematic reviews for falls are well worth reading if you want good science behind you. Or you can cut to the quick and ask NICE to do that for you.
And I know we've talked about NICE before in our hip fracture review, but what does NICE say about falls?
Yeah, so NICE has really good guidance, really clear guidance as to what work. But what it's arguing essentially is that you need multifactorial assessment. So you want to take a falls history, you want to look at patients' gait and balance and mobility, you want to think about osteoporosis risk, you want to think about their functional abilities, their fear of falling, you want to look for sensory impairments, particularly visual impairment, cognitive problems, neurological problems. Continence issues are really important. People hurrying, frightened of being incontinent, transferring to the toilet at night. Continence issues are a really big issue. You need to think about the home environment that are people in. And though I've decried it in everything we've said up until now, you do want to look at the heart and think about their medication. So that sort of complex assessment needs to be happening. It's a multifactorial assessment. And then the interventions that seem to work are strength and balance training. So we know probably for somebody who's younger and more robust than Grace, strength and balance classes to build up her confidence and her safety have been shown to be beneficial. Home hazard assessment, occupational therapy input has been shown to be helpful. Doing something about people's vision is important. And there's a beautiful paper by Rowan Harwood in Nottingham demonstrating that if you expedite somebody's cataract surgery, get their first cataract out as soon as possible, you'll reduce their risk of falls and possibly even a fracture. And medication review is there again and again and again as an important intervention. So those are the things that you need to pull together. And that's what a falls service, perhaps in day hospital, in outpatients, or in the community would be configured around, trying to deliver that multifactorial assessment, multifactorial intervention. And it ought to work. It works in the trials underpinning it. The problems are that it's not cheap. That's a lot of things needed to be done, potentially by a lot of different people. And for some of those interventions, you're talking about repeated visits to the patient or the patient's visit to you over the course of weeks or months to make a real impact. So these are not cheap interventions. And if you're doing a course of exercise work, what happens when the exercise finishes? Is the benefit going to be persistent? Or like drug treatment or something, if you stop taking the drug, does the benefit wear off? And it seems likely that they do. And there is an issue in terms of the cost implications of all of this. Doesn't mean it's not worth doing, but whether it all translates into reductions in falls numbers on a population basis is still a question that we really haven't got a good answer for. So it's a challenge to organise in the community, but it's also a challenge for us when we try and take what we've learned from all of that and apply it to Grace, who's lying in front of us with a broken hip.
And as I was just about to say, let's take it back to Grace. She's come in with a broken hip. For those of you, if you don't remember, she's an 83-year-old female, and she's been in hospital for a few days. She's had a successful surgery. What can we do as the multidisciplinary team to really help stop her having any more falls?
Yeah, so we need to have an approach that's geared to her and her particular needs, but particularly to the context of an inpatient with a risk of falling. And how do I approach falls prevention for somebody who's had hip fracture? The first line that I would take there is that what I'm trying to do for her is what I've tried to do for her in all of the previous podcasts. What she needs is comprehensive geriatric assessment. She needs us to think about all of the factors that we talked about in the NICE guidance on falls prevention, which are suspiciously similar to all the factors we talked about in the podcast on delirium management. We need to be thinking about how we put together comprehensive geriatric assessment. What I would ask her, and what I would expect you as a junior doctor seeing her when she first presents, is to try and take a falls history. So what are you trying to get from a falls history?
I guess from a falls history, you want to try and think of what risk factors she might have that could lead to a fall. So how's her cognitive, is she cognitively impaired? Does she, I think a few things I mentioned earlier, but does she have a walking stick? How's her balance? It's hard to think of these things off the top of my head. But
so you won't be able to do it off the top of your head. You would be able to do it if I gave you a list of all of those things to do. But I'll bet you'd get bored at doing it. And actually, it makes for a very unhealthy conversation with somebody who's lying in front of you with a broken hip, and you've got a checklist of things you need to check through. It's not easy to do that. The approach that I take, and I think is really important, is that your first conversation with Grace, when you meet her for the first time, is such an important opportunity to do so many things. And what I mean by a falls history is I want to give her the opportunity to start talking to me and to tell me a story, and to tell me the story of why she fell over. And then for me to shut up and stop asking her and badgering her with extra questions, but to just let her to tell the story in her own way, in her own time, while she's taking time. And I know I'm terribly busy, but while she's taking time to do that, I'm assessing her language, her vision, her hearing, her cognition, her attention. So I'm carrying on doing a comprehensive geriatric assessment while she's laying out the events that led to her fall. And you can then get a sense of whether actually it was she fell over the mat. There was something clearly as an explanation that isn't medical, or whether there are hints towards some sort of medical underlying event, any suggestion of dizziness or giddiness, or a fall from lying to standing, or something like that would trigger a need to look for medical causes. While I'm listening, I'm getting a sense of her cognition and her sensory difficulties, because they may be particularly important. And then you're a junior doctor, you like doing tests, or you like being sent away to be organising tests. So what tests do we need to do?
Well, a budding junior doctor, as the ward monkey, you could say, I know we mentioned cardiology. I want to see how her heart's doing, as well as her blood pressure. So with her heart, I'm thinking maybe an ECG or a 24-hour Holter.
Yeah, so an ECG is a really important thing to do. You've got a history from her. You've got a sense of whether you believe there might be some cardiological event. You need that before you look at the ECG. You don't just do ECGs blind. So you need to know, but then look at the 12-lead ECG, because you're much more likely to find evidence for an arrhythmia on a 12-lead ECG than you are in any other way. 24-hour tapes, we don't do 24-hour tapes for people who presented with falls. So if you do a 24-hour tape on me now, there's a fair chance you'll find an abnormality. That's clearly not associated with falls, because I haven't fallen over. It's just something that you'll find. So you'll find false positives on that lead to all sorts of confusion. What you might think about in terms of worrying and investigating for arrhythmia in more detail is where you've got a good history of a syncopal event, and you've looked at the blood pressure, and you're clear in your own mind that what she's presented with could well be a cardiological event. That's very unusual. And then if you're going to investigate it further, I suspect you'd be doing an echo before you'd be thinking about ECG monitoring. But that's a very small proportion of patients we see. Then blood pressure.
Blood pressure. Guess you could just do normal, cuff blood pressure, or if you do maybe lying and standing or sitting and standing.
Yeah, so all of the guidance on falls prevention says you need to be doing lying and standing blood pressure. I wouldn't like to try and explain that to Grace, because she's lying there, she's got a broken hip. And you can't do lying standing blood pressure on her. We could plan to do it in a couple of weeks' time if she happens to be in hospital and we happen to remember. But at the moment she's lying there, she's got a broken hip. I can't. I'll get a false negative if I try and do lying standing blood pressure on, because she won't be able to stand up. If she could stand up, her blood pressure is going to drop because she's just bled 2 pints into her fracture. So she's going to be hypovolemic. So you'll get a false positive and a false negative. It's a meaningless investigation to think about at this point. Except if you start thinking about it, you'll start saying, so how would I, given that she's got a history that suggests that she might have been a bit lightheaded when she was upright, how do I respond to that? And I respond to that by stopping the drugs that might cause it. So there's the opportunity before she goes to theatre where she's at risk of low blood pressure causing kidney problems, delirium. There's the opportunity to get rid of some of the potentially causative drugs now, and then think about reintroducing them judiciously after surgery if her management requires it. You want to be cautious in stopping an alpha blocker in a chap who might go into urinary retention, or in somebody who's got a convincing history of ischemic heart disease. You'll have a need not to stop beta blockers, whereas vasodilators you might be more liberal about. But we'd normally be stopping ACE inhibitors and ARBs before sending somebody to theatre anyhow. So we can respond, if we think about how our lying and standing blood pressure is behaving, we can respond before we even send her to theatre, and then use the rest of the time to manage that.
Okay, and so this really, I like the point on polypharmacy and how much that can affect falls. In terms of the rest of the wider MTT, so our OTs, our physios, what can they do for Grace to really help her?
Yeah, so what we need to be doing is feeding our anxiety that this person's falls were related to strength and balance problems or related to the home environment. That needs to be part of what's shared in the multidisciplinary working, because they're the experts in dealing with those. And making sure that patients have the opportunity to have home assessment, which largely now means that the community rehabilitation in somebody's own home is doing an assessment of the home environment as soon as they get home there. That anticipatory questions from the OT to the family or to carers allow adaptations to be thought about before a patient even goes home. But letting the OT do her job properly, and letting the physiotherapists do their job properly, which is not just propping somebody up with a Zimmer frame and getting them out of hospital, but it's allowing the rehabilitation to continue to completion after they've gone home. All of that really is vital. And discharge isn't the end of falls prevention for Grace. So there's a lot we can do. But we also need to remember that she's got a 1 in 4 chance of going on to have another fracture, probably related to a fall in the future. And everything that we can do is of benefit. One of the great challenges that we face is that by rehabilitating her more effectively, getting her up and more active and more going out, she's more ambitious in what she's doing. That's life. That's what we're trying to achieve. But we are increasing her risk of falls if we're letting her go out into the community and go back to playing golf or whatever. That's all a good thing, but it may mean that we're not going to necessarily prevent her having a fall in the future. She'll just have a fall while doing something really interesting in the future. It's a good thing. The treatment that might be helpful to her, though, would be to treat her osteoporosis, because if she has a fall, it would be nice if she doesn't break. And that's a topic that we need to catch in our next podcast.
Well, yeah, that leads us nicely on to hopefully our last podcast of the season. I hope you've enjoyed this one. It's been really informative, as always, Prof. Johansson, and thank you all for listening. I'll include the references as well as any other links in the bio, and we'll catch you next time. Thank you so much.